Welcome to the Hospital Medicine Unplugged podcast. Today we're performing a deep dive into, well, one of the most high-stakes but sometimes deceptively quiet metabolic crises we manage in the inpatient setting. Hyperosmolar, hyperglycemic state, or HHS.
It really is a crisis that demands our utmost attention. While diabetic ketoacidosis DKA often gets more airtime in our metabolic discussions, HHS actually carries a significantly higher mortality rate.
A much higher.
Yeah, we're talking about rates often exceeding 10%, sometimes even hitting 20% in the most critically ill groups. And that's largely because it tends to affect older adults, often folks with severe underlying comorbidities.
I always think of HHS as one of those situations where the basic management protocol looks almost deceptively simple on paper, right? Fluids, potassium, then insulin. But the actual execution, especially in a frail older patient, can be, well, terrifyingly complex. So, our mission today is to really conduct a detailed review. We want to nail down the definition, explore the critical differences in pathophysiology that separate it from DKA, and most importantly, walk through the evidence-based, multi-pronged, sequential management strategy. We'll be guided mainly by the latest consensus recommendations, primarily from the American Diabetes Association.
And really focus on that precision required, especially with managing those fluid shifts and aiming for that controlled glycemic descent.
Exactly. So let's start right at the beginning. How do we define this crisis? Setting those diagnostic ground rules.
Okay, so for the practicing physician encountering this, recognizing HHS really requires hitting a specific diagnostic triad. And you often see this in a patient who just looks profoundly depleted, maybe neurologically impaired.
Right. The triad, based on the ADA criteria, it's our initial go-to screen. So first, you look at the sheer magnitude of the hyperglycemia. Plasma glucose needs to be greater than 600 milligrams per deciliter.
Just astronomical levels.
Huge.
And following that extreme glucose, you look for the real signature of the syndrome, severe hyperosmolality. We define this using the calculated effective serum osmolality. That number needs to be greater than 320 millikilomoles per liter.
And that osmolality, that's the real driver of the clinical picture, isn't it?
It is. It's what causes the most danger, especially neurologically.
Okay, so glucose 600, osmo 320. What's the third piece?
The third factor is really what separates HHS from DKA. And that's the minimal or absent ketosis. You have to confirm there's no significant acidosis. So arterial pH is usually relatively preserved, typically above 7.3.
Okay.
And bicarbonate is usually above 18 millimoles per liter. Plus, you look for minimal ketosis itself, maybe measured by beta-hydroxybutyrate, generally less than 3.0 millimoles per liter, or just minimal urine ketone positivity, maybe 1+ or 2+ at most on the strip.
Right. So if you do have significant acidosis or really heavy ketosis, you're not dealing with pure HHS anymore. You're probably in that murky area of a mixed DKA HHS picture, or just pure DKA.
Exactly. And that changes things. That demands a more aggressive, probably earlier approach with insulin.
Got it. So let's talk about the typical patient. Who are we usually seeing with HHS?
Well, the clinical picture is often stereotypical, but we can't get complacent. Usually you're dealing with an older adult, almost always someone with known type 2 diabetes, or sometimes, as we'll get to, undiagnosed type 2. And they often present with this really dense history of underlying chronic illnesses. Think advanced heart failure, maybe chronic kidney disease, perhaps underlying dementia. All things that severely complicate the aggressive fluid resuscitation we know they need.
That's a critical point, that chronic illness burden. It makes the management so much harder. But it's also vital to remember we shouldn't only suspect HHS in known diabetics, right?
Absolutely not. The sources are clear on this. HHS can actually be the initial presentation of diabetes in, well, up to a third of cases.
Yeah, 1/3.
Yeah, so that makes broad screening really essential. If you have an acutely ill, elderly patient, maybe confused, unknown history, checking that glucose and calculating an osmolality isn't optional. It's basically mandated.
So moving to the presentation itself, what's the hallmark? How does it typically unfold?
The key hallmark is really the insidious onset. DKA often hits fast, maybe over 24 hours. HHS, because it's driven by that relentless osmotic diuresis, it tends to develop slowly, often over several days, maybe even a week or more.
Okay.
So the patient might give you, or a family member might report, this antecedent history of increasing polyuria, polydipsia, maybe significant weight loss over that period.
But usually it's not the peeing or drinking that actually brings them to the hospital, is it?
Rarely. The clinical clue that usually forces the issue, that makes someone call 911 or bring them in, is that profound neurological change, that altered mental status.
Right.
It can range from just simple confusion or lethargy all the way to full-blown coma. And that's a direct result of the extreme hyperosmolality messing with the brain.
And that neurological impairment, it directly tracks with the osmolality level, doesn't it? I remember reading studies showing that strong correlation.
Very strong correlation. Once the osmolality gets over 320 milliosmoles per liter, you start seeing confusion. If it pushes up towards 340 or higher, the probability of frank stupor or coma just increases exponentially.
And then on exam, what are the classic physical findings?
Well, the degree of volume depletion is just staggering. These patients often have total body water deficits that exceed 8 to 12 liters. I mean, think about that volume loss.
That's massive. So clinically, you're going to see really dramatic signs of dehydration, poor skin turgor, really dry mucous membranes.
Tachycardia for sure, sometimes hypotension if they're bordering on shock.
And crucially, you usually don't see cuspal respirations, right? That deep, rapid breathing you see in DKA.
Correct. That's a helpful negative finding. Because there's minimal significant metabolic acidosis in pure HHS, there's nothing really driving that compensatory hyperventilation.
Okay, so we've defined it, we know who gets it and how they look. Let's move beyond that and really unpack the underlying biology. Because understanding the mechanism, I think, is the only way to really rationalize the timing and the sequence of our treatment.
I completely agree. The engine driving HHS, it really hinges on a relative deficiency of insulin. Not absolute, but relative. Combined with this overwhelming spike in counter-regulatory hormones, things like glucagon, cortisol, catecholamines, growth hormone.
So it's like a perfect hormonal storm.
It is. And this storm forces the liver into extreme overdrive. It maximizes hepatic gluconeogenesis, pumps out glucose, while at the same time it reduces peripheral glucose uptake by muscle and fat tissue.
And that just culminates in these astronomical hyperglycemia levels we see, over 600, sometimes over 1,000.
Exactly. But the critical subtlety here, the key pathophysiological point that differentiates it from DKA, is that relative insulin activity. In HHS, especially in type 2 diabetics, there's usually still a small residual amount of endogenous insulin floating around.
Okay, just enough to do what?
Just enough to put the brakes on lipolysis, the breakdown of fat into free fatty acids. If you suppress lipolysis, you prevent the massive production of ketone bodies, like beta-hydroxybutyrate.
And if you prevent ketone production, you prevent the severe anion gap metabolic acidosis. That's the hallmark of DKA.
Precisely. So it's that subtle difference, that little bit of residual insulin that really guides the management speed. Because we don't have severe acidosis breathing down our necks, we have the luxury, or maybe the requirement, to correct the volume deficit and the hyperosmolality before we jump in aggressively with insulin.
That makes perfect sense. It explains the sequencing. And this leads us right to the core driver of the danger in HHS, which is that extreme osmolality itself.
Right. That severe hyperglycemia essentially turns the vascular space into a hypertonic soup. This kicks off massive, relentless osmotic diuresis in the kidneys.
So the kidneys are just trying to dump glucose, but they take huge amounts of water and electrolytes with it.
It's exactly. Leading to profound losses of free water, but also massive electrolyte losses. Talking potassium, sodium, magnesium, phosphate. Sometimes even thiamine gets flushed out in the process.
And as that water loss continues unchecked, the plasma osmolality just skyrockets, way above that 320 milliosmoles per liter threshold.
And this hypertonic environment literally pulls water out of every cell in the body, including the brain's neurons, causes cellular dehydration everywhere.
Okay, now here's where we get into that really interesting physiology, the deep dive nugget you mentioned earlier, this idea of idiogenic osmoles.
Yeah, this is fascinating. So in response to prolonged hyperosmolality, the brain actually tries to protect itself from shrinking too much. It does this by generating or accumulating other solutes inside the neural cells.
Okay.
These solutes, which are the usual electrolytes, are called idiogenic osmoles. They essentially increase the internal osmolality of the brain cells to try and match the high osmolality outside in the serum. It helps normalize the pressure gradient so the brain doesn't just shrivel up.
Okay, wait, let's pause on that because that's crucial for treatment. So the brain has adapted to this high osmolality state by creating its own internal osmoles.
Correct.
So what happens then when we come along and rapidly infuse hypotonic fluids or aggressively drop the glucose with insulin?
Well, you're suddenly lowering the serum osmolality outside the brain cells, much, much faster than the brain can get rid of those newly generated internal osmoles.
So now the brain cells are suddenly hypertonic compared to the surrounding serum.
Exactly. And water, following the osmotic gradient, rushes back into the brain cells to try and reestablish equilibrium. That influx of water causes cellular swelling.
Which is cerebral edema.
A devastating, often fatal complication. Now, it's admittedly rarer in adults with HHS compared to, say, kids presenting with DKA, but it absolutely can happen, especially if the correction is too rapid. This is precisely why the pace of correction is paramount.
So we're managing these two competing emergencies simultaneously. The immediate threat of circulatory collapse from dehydration and the potential iatrogenic threat of cerebral swelling if we fix things too fast.
Perfectly put. That's the tightrope we walk.
Okay, that rationale perfectly frames why the primary goal of resuscitation isn't just about lowering the glucose number on the screen. It's about correcting that osmolality gradually, safely. But before we even touch the treatment lever's fluids, insulin, we have to vigorously pursue the precipitating factor. Why did this happen now? That search for why?
Absolutely essential. And in the hospital setting, what we find most often is infection. Infection is the most frequent trigger, probably accounting for 30% to 50% of cases in hospitalized patients.
And what kind of infections are we usually looking for?
The classic culprits are things like pneumonia, urinary tract infections. The acute inflammatory stress just drives up those counter-regulatory hormones we talked about, completely overwhelming whatever residual insulin activity the patient had.
Okay, so infection is number one. What else is high on the list?
Beyond infection, you absolutely have to conduct a granular, really detailed medication review. Certain drugs are notorious for impairing glucose tolerance or promoting dehydration, essentially setting the stage for HHS.
Like what? What should we be specifically looking for?
Well, diuretics are a big one, especially thiazides or high-dose loop diuretics. They accelerate volume loss. Corticosteroids, obviously, are major offenders, causing massive insulin resistance.
Right.
And we shouldn't forget certain second-generation antipsychotics, things like olanzapine or clozapine, which are known to exacerbate hyperglycemia and weight gain.
Good point. And what about other acute illnesses?
Definitely. Let's not overlook the less common but equally dangerous triggers. Any major acute illness, think myocardial infarction, stroke, pancreatitis, provides tremendous physiological stress that can tip someone over. And furthermore, sometimes it's simpler things. Severe non-adherence to their existing diabetes therapy, maybe they ran out of meds or stopped taking them, or even something like the inappropriate use of hypertonic tube feeds in a nursing home patient without adequate free water and monitoring. That can definitely do it.
So it requires some real detective work sometimes, looking for that trigger in the ER or on admission.
It does. You have to piece together the history, the meds, the recent events.
Okay, so given how critically unstable these patients often are when they arrive, our initial assessment has to prioritize immediate life-saving actions that go way beyond just checking the sugar.
Absolutely. The immediate priorities are always the ABCs: airway, breathing, circulation. If you have a patient presenting with profound depressed consciousness, maybe GCS less than 8, immediate intubation for airway protection and managing aspiration risk is often necessary.
And these patients, they're almost invariably going to the ICU, right?
Almost always. They require continuous hemodynamic and metabolic monitoring that you just can't provide safely on a general medicine floor. ICU admission is indicated for most.
And that monitoring needs to start immediately. Continuous cardiac monitoring is essential, isn't it? Not just because they might be in shock, but because of the huge risk of arrhythmias.
Huge risk stemming from profound electrolyte disturbances, particularly with potassium. The potassium safety check we'll talk more about. It basically starts the second the patient rolls in the door. You need to know that number.
Okay, so ABC secured, patient on the monitor. What's next in the immediate workup?
As soon as we get them stabilized and hooked up, a mandatory and serial laboratory evaluation begins. This involves plasma glucose, electrolytes paying super close attention to sodium and potassium renal function with BUN and creatinine, and getting an initial acid-base status, usually with a VBG or ABG.
And when you say serial, how often are we checking these initially?
Hourly. At least hourly initially. Sometimes even every 30 minutes if they're hemodynamically very unstable or you're making rapid changes.
Yeah. Okay. And this data immediately lets us calculate that critical metric we keep talking about, the effective serum osmolality. Remind us of the formula again.
Yeah, it's essential. 2 times the measured serum sodium plus the plasma glucose in milligrams per deciliter divided by 18. That calculation confirms the diagnosis if it's over 320 milliosmoles per liter, and it gives us our benchmark for guiding the pace of correction later on.
And crucially, we also need to calculate the corrected sodium, right? This seems like a step that sometimes gets overlooked in the rush.
It does, but it's vital. Remember, that extreme hyperglycemia pulls water out of the cells and dilutes the plasma, artificially lowering the measured serum sodium. The corrected sodium tells you what the true sodium concentration would be if the glucose were normal, say 100.
And the standard correction factor is adding 1.6 milliequivalents of sodium for every 100 milligrams per deciliter of glucose elevation above 100.
That's the commonly used one, yes. Some sources might use slightly different factors like 2.0 or 2.4, but 1.6 is standard. The key is to do the calculation.
Okay, so why is that corrected sodium number so vital? How does knowing if it's actually high, despite a low measured sodium, change our initial fluid choice?
That's really the crux of the fluid decision-making after the initial stabilization. If your measured sodium is low, your first instinct might be, okay, give 0.9% saline. But if you calculate the corrected sodium and find it's actually high, say 150 or 155 millimoles per liter, that tells you the patient has a devastating free water deficit, not just a volume deficit.
Ah, okay.
So once you've achieved some initial volume restoration with isotonic saline, a high corrected sodium strongly signals that you need to transition more quickly to hypotonic fluids, like 0.45% saline. Because replacing that pure free water loss is what the patient desperately needs to correct the hypertonicity.
Got it. That makes a huge difference in fluid strategy. Now, concurrently with all these intensive metabolic checks, we have to launch that aggressive screening for the underlying cause, the trigger.
Right. While we're waiting for those initial labs, we need a complete blood count, a urinalysis, definitely a chest radiograph, and blood cultures drawn promptly.
And we need to be ready to pull the trigger on empiric antibiotics if infection seems likely, right? Because waiting for cultures could be fatal.
Absolutely. If the index of suspicion for infection is high fever, leukocytosis, concerning chest x-ray or urinalysis, you start broad-spectrum antibiotics immediately after drawing cultures. The underlying infection is fueling the fire and contributes hugely to that terrifying mortality risk.
Yep.
You can always narrow or stop them later based on results.
Okay, so this initial stabilization and assessment phase maybe takes the first hour or two. Only then, once we have a handle on things, are we really ready to transition into the evidence-based acute management pillars, which have to be done in a very specific, structured, and prioritized order.
Exact. Sequence is everything here.
So let's begin where the crisis truly begins, that massive volume deficit. Fluid resuscitation is the undisputed cornerstone, the absolute first step.
Absolutely. Non-negotiable first step. We have to rapidly restore circulatory volume and tissue perfusion. The immediate danger is hypovolemic shock. So initial therapy is almost always high-volume intravenous 0.9% saline isotonic saline.
And we're talking aggressive rates here, aren't we?
We really are. For a typical hemodynamically unstable adult, assuming they don't have known severe heart failure or end-stage renal disease where you'd be more cautious, the initial infusion rate should probably be 1,000 to 1,500 milliliters of 0.9% saline in the first hour alone.
Wow.
We're aiming to start replacing that massive 8 to 12 liter total body water deficit. The average replacement needed is often around 9 liters over the first 48 hours. So front loading is key.
But that kind of aggressive rate requires extremely careful titration and monitoring, doesn't it? Especially if you are worried about underlying heart failure, which, as you said, is common in this population. How do the guidelines advise monitoring for iatrogenic fluid overload?
Yeah, that's the balancing act. It forces us to rely heavily on frequent clinical reassessment and ideally some form of hemodynamic monitoring. We need to be checking blood pressure, heart rate, jugular venous pressure, urine output, and doing lung exams, looking for crackles basically every hour, if not more frequently. In the ICU setting, tools like central venous pressure, CVP monitoring, or even better, basic bedside POCUS point-of-care ultrasound, looking at the IVC or for B-lines in the lungs, become really essential tools to gauge volume status more objectively. Trying not to fly completely blind.
Right, trying to restore perfusion without drowning them in acute pulmonary edema.
Exactly.
Okay, so after that initial bolus, maybe the first liter or two of normal saline, the patient starts to stabilize hemodynamically. Then we move into phase 2 of the fluid plan, which relies heavily on that corrected sodium calculation we talked about earlier.
Correct. After that initial resuscitation, say 1 to 2 liters of 0.9% saline are in, you reevaluate the corrected serum sodium. If it's normal, say 135, 145, or high, above 145, that's your cue to pivot to hypotonic fluid.
Usually 0.45% saline, half normal saline.
Typically 0.45% saline, yeah. You'd infuse that at a slower but still significant rate, maybe 250 to 500 milliliters per hour, depending on the ongoing deficit and hydration status. This hypotonic solution provides the necessary free water replacement to gradually start correcting that hyperosmolality.
Okay. And conversely, what if the corrected sodium is still low after the initial boluses, meaning they've lost significant salt along with the water?
Good question. If the corrected sodium remains low, say below 135, then you'd continue with 0.9% saline at that 250-500 milliliters per hour rate until the sodium level normalizes. You wouldn't switch to hypotonic fluid yet because you don't want to drop the sodium or osmolality too quickly.
So it's this individualized titration based on serolabs that prevents those very rapid drops in osmolality that could lead to cerebral edema.
Exactly. It's all about tailored, monitored replacement.
And speaking of safety and pace, this whole restoration process, especially correcting the osmolality, it cannot be rushed, can it? What are the target rates we're aiming for?
No, rushing is dangerous. The goal is a gradual, controlled correction. The recommended rate of glucose decline once insulin is started is about 50 to 75 milligrams per deciliter per hour.
Okay.
And critically, the osmolality correction itself should not exceed 3 millismoles per liter per hour. That's the key safety ceiling.
3 per hour. What do you do if you calculate it and find it's dropping faster than that?
You have to immediately slow down your fluid rate, maybe switch back to a more isotonic fluid temporarily if you're using hypotonic. You have to put the brakes on. Exceeding that 3 millismoles per liter per hour rate significantly increases the risk of cerebral edema. This measured approach is really the difference between saving the patient and potentially causing a devastating neurological injury.
Okay, that measured approach to fluids and osmolality correction perfectly transitions us to the next mandatory step in the sequence, the critical potassium safety check. This is absolutely essential for avoiding sudden, life-threatening arrhythmias.
Couldn't emphasize this enough. Despite the initial labs, which might show normal potassium or even sometimes high potassium.
Which seems counterintuitive, right? Given the total body loss.
It does seem counterintuitive, but it's common. It happens because the lack of insulin action and the hyperosmolar state itself cause potassium to shift out of the cells and into the bloodstream, artificially inflating the serum level. But make no mistake, the patient's total body potassium is profoundly depleted. That osmotic diuresis has simply flushed huge amounts of it out via the kidneys over the preceding days or week.
So we have to anticipate that as soon as we start aggressive fluid resuscitation, which dilutes the serum potassium, and then eventually when we start insulin, that extracellular potassium is going to get driven back into the cells very quickly.
Exactly. And that can cause a precipitous drop in the serum potassium level, potentially leading to severe life-threatening hypokalemia if we haven't started replacing it.
Okay, so potassium replacement is mandatory. When do we start it, and how much?
It's mandatory, and it needs to begin pretty much immediately once you've established that the patient has adequate urine output, meaning their kidneys are working, and you've confirmed that the serum potassium is less than 5.3 millimoles per liter.
So not if they're truly hyperkalemic initially.
Correct. If it's 5.3 or higher, you hold off on adding potassium initially, let the fluids and eventual insulin start working, and recheck frequently. But if it's below 5.3, you typically start by adding 20 to 30 milliequivalents of potassium, usually potassium chloride per liter of intravenous fluid you're infusing. That starts the process of replenishing that huge total body deficit.
Okay, 20 to 30 milliuq per liter once K is 5.3 and they're making urine. Now, here comes the absolute red line, the critical safety stop you alluded to earlier regarding insulin.
Yes, this is the point that cannot be stressed enough. Insulin therapy must be withheld if the serum potassium is less than 3.3 millimoles per liter.
Full stop. Don't start insulin if K 3.3.
Full stop. This is non-negotiable. Insulin is a potent driver of potassium intracellularly. Giving insulin, even a small amount, in the setting of severe hypokalemia, K 3.3, will precipitously drop the serum potassium even further.
And that can lead to?
Life-threatening cardiac arrhythmias, ventricular fibrillation, potentially even asystole. It's incredibly dangerous. So you must aggressively correct the potassium deficit first. Give IV potassium pushes, increase the concentration in the maintenance fluids, whatever it takes. You need to aim to get that potassium level safely above 3.3, ideally closer to 4.0 millimoles per liter before you even think about turning on the insulin pump.
Okay, that's crystal clear. Fluids first, potassium check and replacement initiated, if K 5.3. Potassium corrected if 3.3. Only then, once fluid resuscitation is well underway, volume status is improving, and the potassium levels are stabilized in a safe range, do we finally move to the third pillar of management, controlled insulin therapy.
Exactly. And again, the timing here is just as important as the dosing.
Why the delay in starting insulin, fundamentally?
The delay is crucial, primarily to protect the brain. We must ensure that volume resuscitation has begun and the osmotic pressure is already being slowly reduced by the fluids before we add insulin's potent glucose-lowering effect. Starting insulin too early, when the patient is still profoundly volume depleted, can exacerbate the fluid shifts and potentially increase the risk of those rapid osmotic changes that might lead to cerebral edema.
Okay, so what is the primary role of insulin in HHS management once it's safe to start?
The primary role of insulin here is really twofold. First, it directly lowers the blood glucose by increasing peripheral uptake and decreasing hepatic glucose production. Second, and perhaps just as importantly in stopping the cycle, it shuts down any residual hepatic gluconeogenesis and glycolysis. By correcting the hyperglycemia, it ultimately helps arrest that vicious cycle of osmotic diuresis.
Got it. So what are the consensus guidelines from the ADA or AZE on the dosing protocols? How do we typically start insulin?
The standard recommendation is to initiate a continuous intravenous infusion of regular insulin. We're not usually using subcutaneous insulin in the acute phase. The goal is a moderate, steady dose, typically starting at 0.1 units per kilogram per hour.
Okay, 0.1 units GAR, continuous IV infusion. What about an initial bolus? Some DKA protocols use one.
Some protocols do include an initial IV bolus of regular insulin, maybe 0.1 units per kilogram, followed immediately by the continuous infusion at 0.1 units GAR. The idea there is to achieve a faster initial onset of action.
However, I feel like I've seen some centers, particularly for HHS, where the concern about rapid osmotic shifts is higher, leaning away from using a bolus altogether, maybe favoring just starting the infusion, perhaps at a slightly higher rate initially.
Yes, that's definitely a trend and a valid approach. Some protocols now favor avoiding the bolus entirely in HHS and just starting a continuous infusion, maybe at 0.14 units per kilogram per hour without the initial push.
And what's the rationale there? Does that align better with the principle of controlled gradual descent?
It absolutely aligns with that principle. The avoidance of the bolus, and perhaps using a slightly higher steady infusion rate initially, is purely about preventing those sudden, potentially uncontrolled drops in glucose and consequently osmolality right at the beginning. The emphasis in HHS, given that cerebral edema risk, is really on precision and achieving a steady state decline.
That makes sense. Control over speed.
Exactly. And this is where standardized protocols become so important. Using nurse-driven or computerized IV insulin protocols, especially in the ICU setting, is strongly recommended. They significantly improve glycemic control, they help prevent human error in calculations and adjustments, and they've been shown to minimize the associated risk of hypoglycemia, which is another major concern.
Okay. So we've got the insulin infusion running, fluids are going, potassium is being managed. There's a critical inflection point in the therapy, right? A point where the primary danger shifts, and we need to make significant adjustments. When does that happen?
Yes, there's a very important inflection point. It typically occurs when the plasma glucose falls down to a certain level, generally somewhere below 300 milligrams per deciliter, could be 250 or 300 depending on the specific protocol.
And what changes at that point? Why is glucose 300 milli-GDL so significant?
At this point, the primary immediate danger shifts away from severe hyperosmolality and towards the risk of iatrogenic hypoglycemia if we continue the same insulin rate. Also, there's a risk of causing an overly rapid correction of the remaining osmotic gradient if we continue pouring in hypotonic or isotonic fluids without any glucose source.
Oh, okay. So if we just keep the insulin going and the non-dextrose fluids, the glucose could plummet and the osmolality could drop too fast from that point.
Precisely. Therefore, as soon as the glucose hits that threshold, say 300 milli-GDL, we must switch the patient's intravenous fluids. We need to add dextrose to the maintenance fluids.
What kind of fluid typically?
Typically, we switch to something like D5W, 5% dextrose in water, combined with 0.45% saline, half normal saline. D50, 0.45% saline is a very common choice.
And why that combination?
That combination achieves two critical goals simultaneously. It continues to replace the ongoing free water deficit with the hypotonic saline component, helping to slowly normalize the osmolality. And crucially, it provides an external source of glucose, the D5W, to prevent hypoglycemia as the insulin infusion continues, and it helps maintain a smoother, more controlled decline in osmolality towards the target range.
Okay, so switch fluids to add dextrose when glucose hits around 300. What happens to the insulin infusion rate at that point?
The insulin infusion rate must then be titrated down significantly. Once you add dextrose to the fluids, you often need to reduce the insulin rate, maybe to somewhere between 0.02 to 0.05 units per kilogram per hour.
So roughly halving it or even more.
Often, yes. The goal now shifts to simply maintaining the target glucose range, keeping the patient out of hypoglycemia, while the fluids continue to correct the underlying dehydration and hyperosmolality. You're constantly adjusting the insulin rate based on hourly glucose checks to stay within that target.
And what is that target glucose range we're aiming for during this resolution phase? We know that super tight glycemic control in critically ill patients sometimes backfires.
Right. The consensus target for most hospitalized patients, including those recovering from HHS in the ICU or on the floor, is generally a more moderate range, typically 100 to 180 milligrams per deciliter.
So not aiming for perfect normoglycemia like 80, 110?
No, generally not. Trying to achieve that very tight control has been associated with increased risk of severe hypoglycemia and potentially worse outcomes in broader critically ill populations. So that moderate intensity target of 100 to 180 milli-GDL has been shown in various studies to be effective in resolving the metabolic crisis while minimizing those adverse outcomes, especially hypoglycemia.
Okay, 100 to 180 is the goal once glucose is below 300 and dextrose is added. Now, moving beyond the immediate resuscitation pillars, we absolutely have to remain incredibly vigilant about the whole spectrum of acute complications associated with HHS itself, especially given that high mortality rate we started with.
Yes, the complication list is unfortunately long and serious. The vascular risk, for instance, is immense. Just imagine the patient's blood glucose of 1,000 may be a high hematocrit from dehydration. It's like sludge, incredibly hyperviscous.
Right.
This hyperviscosity, combined with the profound dehydration and often underlying atherosclerosis, leads to a really high risk of vascular occlusions. We have to be actively watching for signs of myocardial infarction, stroke, deep vein thrombosis, pulmonary embolism.
Any other rare but serious ones?
Yeah, even rare but devastating conditions like mesenteric artery occlusion, causing bowel ischemia, or even disseminated intravascular coagulation, DIC, could occur in severe cases. Prophylactic anticoagulation like heparin or Lovenox is generally indicated unless contraindicated.
Okay, so high thrombotic risk. What about the neurologic risks? Besides the initial altered mental status, we talked about cerebral edema.
Right. While, as we said, overt clinical cerebral edema is rarer in adults than kids, it remains a dreaded complication and requires constant vigilance. If you see a patient who seemed to be improving hemodynamically and metabolically, but then their mental status suddenly deteriorates again, or they develop new focal neurological signs, you have to immediately suspect it might be due to a rapid osmotic shift. It suggests we might have corrected the glucose or osmolality too quickly.
And that requires immediate action, like slowing fluids, maybe giving mannitol.
Potentially, yes. Urgent neurology consult, repeat imaging. It's an emergency.
Okay. And then there are the complications that arise from the treatment itself, right?
Absolutely. We've already hammered on hypokalemia, which is a major risk if potassium isn't monitored and replaced aggressively before and during insulin therapy. But hypoglycemia is the other big one.
Especially once you're titrating that insulin drip.
Exactly. If monitoring isn't meticulous, those hourly glucose checks are non-negotiable. It's very easy to overshoot and cause severe hypoglycemia, which can also have serious neurological consequences. That's another reason why those standardized protocols are so helpful.
We also need to remember the other electrolytes that got fleshed out during that massive osmotic diuresis, don't we? Besides potassium.
Yes. Well, potassium is usually the most acutely life-threatening deficit. We also need to monitor and potentially replace phosphate and magnesium, especially if the depletion is severe.
Why is phosphate important?
Severe hypophosphatemia, which can develop during refeeding and insulin therapy, can actually impair cardiac contractility, lead to muscle weakness, including respiratory muscle failure, making ventilator weaning difficult, and cause hemolysis or rhabdomyolysis in extreme cases. So checking phosphate levels serially and replacing if needed is important. Same goes for magnesium.
Okay. And one final specific nuance, especially for patients where you might suspect malnutrition or maybe chronic alcohol use.
Yes, thiamine. Absolute critical point. Thiamine, vitamin B1, is an essential cofactor for glucose metabolism. If you start aggressively infusing glucose, which is exactly what we do when we switch to those D5W-containing fluids in a patient who is already severely thiamine deficient.
You can precipitate Wernicke's encephalopathy.
Exactly. You can unmask or precipitate acute Wernicke's encephalopathy, characterized by the triad of confusion, ataxia, and ophthalmoplegia. It's a neurological emergency. So the standard recommendation is to give thiamine, usually 100 milligram IV or IM, before or concurrently with the first dose of dextrose-containing fluids in any patient considered high risk for deficiency.
Good reminder. Don't forget the thiamine in susceptible patients. Okay, let's transition now to look at the prognosis reality, because the stakes here are genuinely quite high. We established early on that the in-hospital mortality for HHS is rough, maybe 10% to 20%.
Yes, significantly higher than what we typically see with pure DKA, which is usually down in the 1% to 5% range these days in well-resourced settings.
And what factors are most strongly associated with that higher mortality in HHS?
Mortality is very strongly associated with specific factors you can often identify right at presentation. Advanced age is a big one. The presence and severity of underlying comorbidities is another. And critically, the degree of altered mental status on arrival is a major predictor.
So if a patient requires intubation for airway protection or is frankly comatose when they hit the door,
their prognosis is immediately much more guarded. It reflects the severity of the underlying cerebral dehydration and metabolic derangement. Higher osmolality itself also correlates with mortality.
Now, while you mentioned improved management protocols, standardized fluids, insulin drips, better monitoring might have helped decline the inpatient mortality rate somewhat in recent years.
Yes, there's some data suggesting that.
The short-term and especially the long-term mortality after surviving an HHS admission remains alarmingly high, doesn't it?
It really does. Several studies have shown one-year mortality rates exceeding 30% in older cohorts who survive the initial hospitalization. Some studies show even higher rates. It's sobering.
30% one-year mortality. That really tells you that our job as hospitalists is far from over when the glucose finally stabilizes and the insulin drip comes off.
Absolutely. It underscores that HHS isn't just an isolated metabolic storm. It's often a marker of severe underlying physiological frailty and poorly controlled chronic disease. Surviving the acute event is just the first step.
And does the way we manage the acute event influence those longer-term outcomes? You mentioned the moderate-intensity insulin protocols.
Yes, I think it likely does, indirectly at least. Utilizing those standardized controlled glucose reduction strategies, avoiding big boluses, aiming for that stable 100 to 180 range, minimizing hypoglycemia has been shown to reduce the length of ICU and hospital stay and lower the rate of acute complications like hypoglycemia. Fewer complications and shorter stays generally translate to better functional recovery and potentially better long-term outcomes, although proving the direct link is hard.
Okay. This leads us directly into the final, and you could argue perhaps the most challenging phase of managing HHS, the transition of care. This seems to be where many patients falter, leading to those high recurrence rates and contributing to that dismal one-year mortality.
It's arguably the most critical phase for long-term success, yet sometimes gets the least attention once the acute crisis is over.
So when and how do we safely transition someone off an IV insulin drip back to subcutaneous insulin?
The transition should happen only when the patient is clearly clinically stable, the hyperosmolality and dehydration have resolved, the underlying acute illness or trigger is resolving or resolved, and, importantly, they are able to eat reliably. You can't transition someone who isn't taking oral nutrition.
Right.
The transition itself needs to be calculated carefully. You generally need to administer the first dose of subcutaneous basal insulin, like Lantus or Levemir, several hours, usually 2 to 4 hours before you actually stop the continuous IV insulin infusion.
Why the overlap?
To ensure there's no gap in insulin coverage. 5E regular insulin has a very short half-life. If you just stop the drip and give the first sub-Q dose at the same time, the glucose will likely shoot right back up before the long-acting sub-Q insulin kicks in. That overlap prevents rebound hyperglycemia. You also need to plan for prandial mealtime short-acting insulin if they are eating.
Okay, so calculated transition with overlap, but the bigger challenge is preventing recurrence, isn't it? What does a robust discharge plan need to include?
It has to be comprehensive. It absolutely must include critical focus on patient education, tailored to their health literacy level about diabetes self-management. This means reinforcing blood glucose monitoring skills, explaining their new insulin regimen or oral meds in simple terms, teaching signs and symptoms of hyperglycemia and hypoglycemia, and emphasizing sick day rules. And beyond just education, it needs to include a clear, accessible plan to address any barriers to adherence that might have contributed to the HHS episode in the first place. Is it cost of medications? Lack of transportation to follow-up appointments? Poor social support? Cognitive impairment. We need to identify and try to mitigate these barriers before they leave the hospital.
And because if we just fix the numbers from the acute crisis, manage the pneumonia or UTI that triggered it, but fail to solidify that long-term diabetes management plan,
Then we'll almost certainly be back. If we don't ensure they understand their medications, can afford them, know how and when to take them, and have reliable follow-up arranged, recurrence is unfortunately very likely.
Okay. So let's try to summarize the key takeaways from this deep dive on HHS. It seems like the management really boils down to a strictly structured priority list.
It really does.
First, you, the physician, have to stabilize the ABCs, get that continuous monitoring going immediately. Second, rapidly hydrate the patient, starting with isotonic saline, but then adjusting the fluid type likely to hypotonic saline based on frequent reassessment and that crucial corrected sodium calculation.
Correct. Volume first.
Third, you absolutely must conduct that potassium safety check. Assess the level, start replacement if it's below 5.3 and they're making urine, but critically, withhold insulin if it's below 3.3 until corrected.
Non-negotiable safety step.
And only then, fourth, do you initiate controlled IV insulin delivery, usually a continuous infusion without a bolus in HHS, aiming for that gradual glucose decline of 50-75 milligidl per hour.
Right. And all while this is happening, you're vigorously pursuing and treating the underlying cause, most often infection, that triggered the whole metabolic cascade in the first place.
And throughout this entire process, the single most critical factor that seems to differentiate a successful outcome from a potentially devastating one is the rate of correction, isn't it?
Absolutely. The rate of fluid administration and, even more importantly, the rate of osmolality correction is paramount for patient safety. You have to aim for that slow, steady correction no faster than 3 milliosmoles per liter per hour drop in osmolality to mitigate that catastrophic risk of cerebral edema. Slow and steady wins the race in HHS resuscitation.
Okay, so maybe a final provocative thought for our listeners. Considering those consistently high recurrence rates and that alarmingly high post-discharge mortality for patients who survive an HHS admission, maybe you, the hospital physician, need to reframe how you think about the transition of care.
How so?
Well, maybe it shouldn't be seen as the last step in their hospitalization, the discharge checklist. Maybe it needs to be viewed as the critical bridge to their long-term survival. The effectiveness of the discharge planning, the education, the follow-up arrangements, maybe that's actually more predictive of their ultimate outcome than the initial heroic ICU resuscitation.
That's a powerful way to put it. Because the patient's ultimate prognosis, their chance of not just surviving the next year, but thriving, may indeed rely less on how well we manage the first 24 hours of shock and metabolic chaos, and more on the effectiveness and sustainability of the outpatient diabetes management plan that we help establish before they walk out the hospital door.
It suggests that our responsibility as hospitalists in managing HHS extends far beyond just stabilizing the numbers and signing the discharge summary.
It really does. That transition of care, ensuring a safe and effective handoff back to the community with a solid plan, might be the most impactful intervention we make for their long-term health. That's the lasting responsibility.